Hello, everybody, and welcome to the first in our series celebrating Congenital Heart Disease Awareness Week. That's all week this week, just trying to really raise the profile of congenital heart disease across our region. And I'm delighted to be able to welcome Professor Jonathan Wiley, who's a consultant neonatologist from James Cook University Hospital, who's also the chair of our network board in the region. And he's here with us today to talk about those tiniest of broken hearts. So without further ado, I'll hand over to you, Jonathan. Thank you so much.
Well, thank you very much indeed for the invitation. It is, of course, literally a topic that's been very close to my heart for many, many years. So what I'd like to say, first of all, you need to know that there are a few disclaimers. If it gets a bit boring, it's because I love cardiology and I am old. Also, I think the nursing staff I've worked with over the years feel I'm not really complete unless attached to an echo machine. And I think there are a number of my colleagues now following in my footsteps in that way. It's almost become a high-tech Zimmer frame. So what I'd like to do is just go over for neonatal medical and nursing staff why congenital heart disease is so important to at least bear in mind, and hopefully encourage you to find out more about it. We'll look at some of the ways in which congenital heart disease presents in the fetal period on the NICU, and also think about the postnatal ward. And throughout this session, I'd be really grateful if you could just think and bear in mind of the areas in which you work, and just put yourself in the position of just considering why you need to know about congenital heart disease for your day-to-day work supporting babies and parents. So why is it so important? Well, if you look at the prevalence, most textbooks will quote that congenital heart disease affects about 8 per 1,000 live births. But if you look at the data from here, Sunderland and Ashington, we know that it's between 11 to 12 per 1,000 live births. And as we'll mention later on, that makes it the most common congenital abnormality you come across. It also means that there's between 240 and 360 new cases each year in the Northern Deanery across all maternity units. So it is happening every year, each year, and as you can see, almost on an average of one a day. If you look at more recent data in 2018 across England, you'll see that congenital heart abnormalities are the most common abnormality that you can find. You'll see that it's linked to genetic abnormalities in a number of cases, certainly a significant number. And not only is it the most commonly found isolated abnormality, but it's the most commonly associated with other anomalies that may be found. So they are also the leading cause of infant and perinatal mortality. And congenital heart disease, together with chromosomal and digestive anomalies, are most frequently associated with infant mortality. Higher and lower maternal age are linked with an increase to certain congenital abnormalities, but for congenital heart disease, 10.4% of all infants, so in the first year of life, who die have congenital heart disease, and 2/3 of those die due to their congenital heart disease. So it's not only a significant problem, but it's a serious problem in terms of mortality. We can see this here, again, the 2018 data showing various abnormalities linked with mortality in the first year of life, and this is numbers per 10,000 live births. When we look at what kind of things we find, well, ventricular septal defect, so a hole between the two pumping chambers at 34% tops the list. And those, of course, can vary from things that really will need an operation in order to fix and ensure long-term life. And it really is a fix because of the skills of our surgeons and intensivists. Also down to holes that are either going to close themselves or never going to be a problem. But that's still going to worry both parents and indeed clinicians when those babies are readmitted with other issues, if they can still hear a murmur due to the ventricular septal defect. So that makes it important to sort out. You'll see going down the list atrial septal defects and patent ductus that many of us that work in neonatal units are well used to are the next most common, with stenoses and diagnoses such as tetralogy of Fallot, coarctation and transposition of the great arteries making up about 1/20th of what we find. This is a complicated diagram. It's worked by Chris Wren and others looking at how just under 1,600 babies, all with congenital heart disease, presented in the first year of life. And really for today's talk, I obviously want to highlight that top number, that just under a third present before discharge after birth, either because they were known about as a fetus or because they present or something such as a murmur was heard before they went home. So that means that a fair old proportion of babies who are going to present in the first year of life present in that period before they go home. You'll also see that the more that we find, the more that we will reduce those numbers after they go home. And that's what this diagram is really about. It shows that there's a significant number, especially of serious problems, that present before the neonatal examination and then before discharge. But we could reduce those numbers presenting after discharge significantly if we were better at picking up and acting on either our suspicions or our findings. So when we look at early presentation, of course, that may be a presentation as a fetus, and our fetal colleagues are getting better and better at picking up cardiac anomalies, and that can be in some studies up to 50% of what presents. And they are more likely to be the serious abnormalities that present in this way, and we'll talk about that a little bit in a minute. Syndromes and other anomalies we're going to cover, as we are murmurs and cyanosis, and to a lesser degree heart failure, collapse and death. So fetal scans. Well, if you detect an anomaly as a fetus, and this is usually at the 20-week scan, then you can offer parents, depending upon what the anomaly is, the choice of continuing the pregnancy or not, or indeed investigating further if it links up with other anomalies that have been found by the fetal medicine specialists. There's an option to treat in utero. This is seen rarely, but it does happen with structural heart problems, but it's mainly dysrhythmias. If you pick up a heart that is beating in a dysrhythmic way, then it's possible to treat the mother, who then passes on the medication to the baby through the placenta, and actually bring those heart rhythms under control so that they don't end up in failure and hydropic. Or even some of the hydropic ones, if it's due to a cardiac problem, you can reverse that whole process. If you find an abnormality that is going to be born, then there can be a choice of birth venue. This has been shown to change outcomes with transposition of the great arteries, less so with other problems, but of course there is the potential to plan postnatal treatment, especially in the case of duct-dependent malformations where you want to keep the duct open, but also in terms of emergency healthcare plans, sometimes in terms of palliation, and more commonly in terms of what we should do when a baby is born. And even if a baby is due to be born in a tertiary centre allied to a heart unit, and for us that would be the RVI, allied of course to the Freeman Hospital, there is a need for an emergency healthcare plan, because as you'll see, especially significant congenital heart problems in babies are more associated with preterm delivery, and therefore they may turn up anywhere in labour. Oops, sorry. So fetal scan will be done with ultrasound, just as the obstetric scanners have been looking at babies and growth, so they can look at the heart. And one of the most important views is this 4-chamber view. Of course, it's slightly more complicated in that you have a baby that can move around inside his or her mother, but this is the kind of view that obstetric scanners are searching for, with the spine there at the 2 o'clock position and a nice balanced 4-chamber view. We see this in an actual ultrasound here with the right ventricle and right atrium uppermost and the left ventricle and left atrium behind, with the spine marked there. And you can see why actually right and left ventricles were kind of inappropriately named. They should really have been front and back. Here we see one that is not a balanced picture, and you can see the smaller right ventricle marked in the lower right portion, and you can see a large dilated left ventricle. And this is because this is a critical aortic stenosis, and that left ventricle is starting to fail. This baby went on to develop a much more recognizable hypoplastic left heart, but the first stage of this was that the left ventricle dilated up. So finding those can both enable us to sometimes intervene, but also to plan. And I mentioned that syndromes and other anomalies are linked to congenital heart disease, and this is really important because, of course, we see these on the postnatal ward and in the neonatal intensive care unit and SCBUs. If we look at Downs, then Down syndrome in 2018 accounted for 1 in 400 births. Edwards and Patau's also highly associated with congenital heart disease, 1 in 1,300 and 1 in 4,000 births, respectively. And it's interesting that those figures have actually increased. When I was a lad, I was told that Down syndrome occurred in 1 in 600 births, but we've had a shift despite antenatal diagnosis. So you would recognize this. It's interesting that if you talk to the genetics service, they do more than twice as many tests for suspected Downs as are actually Downs diagnosis on a postnatal basis. And yet we see here certainly an appearance that would make us want to test the genetics. And that's important from a congenital heart disease point of view, because whilst the prevalence of congenital heart disease in the general population, as we've said, is 8 to 11 per 1,000 live births, in trisomy 21, it's between 340 and 400 per 1,000 live births, and that's data from our own region. So much more common. Up to 40% of children with Down syndrome will have a heart problem, which is usually a significant heart problem. Of those, just over 40% will have a complete atrioventricular septal defect, and I'll show you a picture of that in a minute. A third are going to have a ventricular septal defect, the next most common, and some of the other problems that we've mentioned before are less well represented, but still significant numbers of anomalies, and that's work by Sir John Byrne in 1987 in our region. So here we see a complete atrioventricular septal defect. You can see on the left of your screen, this is in systole, and there's a common valve across this midline and an atrial and a ventricular component. And the central fibrous body is missing the connection between the right atrium and the left ventricle. And you can see on the right, looking in diastole, the cloverleaf appearance where all 4 chambers are actually open to each other. And that's clearly a big problem, which may or may not produce murmurs early on. So it can just be that you hear a single second heart sound. And so a high index of suspicion is necessary. And ideally, you want to sort out what is going on with each baby with Down syndrome so that the parents can have as full a picture as possible. If we think about surgical anomalies, whether they're presenting and delivering in our own units, or indeed whether we've sent them into the RVI and they may well be delivering for this surgical anomaly, we see that congenital heart disease is strongly associated with a number of surgical anomalies. Exomphalus, depending upon the paper you look at, up to a third will have a heart anomaly. And with a diaphragmatic hernia, that's a fifth. An eighth of imperforate anus babies will have a heart issue as well. And esophageal atresia, also depending upon the series you look at, it's 15 to 40% will have a congenital heart defect. Note that if you have duodenal atresia and you are trisomy 21, then 80% of those babies will have a heart problem. So probably worth echoing them as soon as possible, and certainly before surgery. We think of other things, many of which will present often later, and Marfan syndrome. There may be a family history, but you can see, as here in the top left-hand corner, Marfan syndrome presenting early in life, and this was a neonatal presentation. Marfan syndrome, you need to know that if you have it and you are stretchy, then other things can stretch, like valves and the aortic root, which tends to be a later problem, but I have certainly seen valves become incompetent within the first few weeks of life in a few babies. Noonan syndrome affects 1 in 1,000 to 2,000 babies, can be associated with a dysplastic pulmonary valve and cardiomyopathy. You see the typical web neck on the left-hand side, and these babies often tend to have shield chests and widely placed nipples, and may well have presented in fetal life as having excess nuchal skin and increased nuchal thickness. Worth just thinking about this, because I've certainly seen babies needing respiratory support because of cardiomyopathy, and we've certainly diagnosed it on the neonatal unit and requested genetics opinions because of the appearance of a dysplastic pulmonary valve. And in fact, I suspect that I saw one of twins just recently who may well have Noonan's. Turner syndrome, of course, similar presentation in phenotypically females with a 45X karyotype, tend to be short stature, so maybe a growth issue initially, even as a neonate, and also with the web neck and a number of other potential problems. But for us, the really important thing to think about is whether there's aortic coarctation or indeed bicuspid aortic valve. And they may also suffer from conduction issues throughout their lives. Williams syndrome, much less common, happy, elfin, smiling people. There's a baby at the top, just looking gorgeous, and a similarly gorgeous looking young man down at the bottom. But 80% will have some issue, often a supravalvular aortic stenosis, pulmonary stenosis, coarctation, sometimes renal artery stenosis. And you need to think about this, especially in the neonatal period, if you're dealing with a baby that's got hypercalcemia, because they may well present in that way to a neonatal or special care unit. So with syndromes and other anomalies, a high index of suspicion, and it's worth just asking the question, are we sure that there's nothing else going on, and should we get somebody just to have a look-see if you've already made a diagnosis or you think there's an issue. Murmurs, of course, are the traditional way to present. And in fact, Sean Ainsworth performed work with myself and Chris Wren, looking at just how important heart murmurs were at the newborn examination on the postnatal ward. So this was done originally because previous work that I'd done with Chris Wren made us think it was a pointless task, even listening to the heart. But actually what we found was that although only 0.6 per thousand babies would have a murmur detected, it was worth having a look at that murmur and finding out what it was, because it had a positive predictive value of about 54%. And that's better than most of the tests that we have. Of course, lots of those anomalies were not particularly significant or serious, but it meant that parents went home with a full picture. And some anomalies that we picked up did need intervention, such as coarctation and indeed tetralogy of Fallot. Murmurs, when we think about them on the neonatal intensive care unit, of course, the most common cause, especially amongst our preterm population, is patent duct. But we must bear in mind, as we'll see, more of our preterm babies have congenital heart disease. Once the duct has closed, then the most common cause for a murmur on the neonatal intensive care unit is probably left pulmonary artery branch stenosis, which happens in about a third of all babies as their duct closes. And you can hear that with an ejection systolic murmur that goes to the left axilla but not the right. Otherwise, obstructive heart problems and shunts are the most common cause of murmurs. And with shunts, then, of course, ventricular septal defect is the most common. If we look at this paper again from this region with Neil Sabreen, Chris Wren and Kirsty Tanner as first author, they looked at malformations amongst preterm infants. And the important thing is to realise that our preterm babies are twice as likely as term babies to have congenital heart disease. 16% of all babies with congenital heart disease are born prematurely. And more recent data from 2018 showed that you get the congenital heart disease you have in very preterm babies, 25 to 32 weeks, is 5 times more serious congenital heart disease than you get at term. And importantly, you're 7.5 times more likely to die if you have congenital heart disease as opposed to a baby that doesn't have congenital heart disease. Cyanosis then, another way in which babies can present, and this can be clinically very difficult. We only recognise babies who are less than 85% saturated visually, so it may be missed. And if you have any concerns, there's no room for doubt. And I think that this is a diagnostic emergency, whatever the cause of the cyanosis. Of course, we have particular issues in that on the postnatal ward, we expect babies to have a saturation in the right upper limb of greater than 94% and no more than a 2% difference between the right hand to a foot saturation. It can also be clinically difficult on the neonatal intensive care unit or special care unit because our preterm babies we keep within a range of 90 to 95%. But you need to think, where do you keep your limits in order to target that? Because it may well be that your limits encompass where normally cyanotic babies, because of their congenital heart disease, may be sitting. And that has certainly happened to me where a nurse has looked after a baby that has got better from its respiratory distress syndrome and said, so why are the saturations so often just a bit lower than I want them? And of course you look at that baby and then you find out that actually the baby had transposition of the great arteries. So it may be missed. The other way in which we can sometimes miss cyanosis is that term babies represent a relatively low proportion of the babies that we look after on special care units and neonatal intensive care units. And so we are really conscious of not overdoing it with oxygen, and so we don't necessarily take on board that term babies require their saturations to be greater than 94%. Again, I think it's a diagnostic emergency and you need to be sure you know what you're dealing with. That's especially true of persistent pulmonary hypertension of the newborn. So we think we all know what this is, but we always have to think, is that what we're dealing with? And here we have a situation and a case which is pretty recent for us, whereby a baby was transferred for persistent pulmonary hypertension of the newborn, but actually what we were actually dealing with was total anomalous pulmonary venous connection. And here you can see above the left ventricle and the left atrium, there is a pulmonary venous connection chamber here above, and that actually connects, although in this diagram it connects to the superior vena cava. In our case, it actually went through a vessel south and connected with the portal venous system, and that gave you a cyanotic baby who did not respond to our treatment for persistent pulmonary hypertension of the newborn, not surprisingly, because that wasn't the problem that the baby had. Another issue which can give you a cyanosis, of course, is transposition of the great arteries, as seen here. And here we see the pulmonary artery coming out of the left ventricle and the aorta side by side, and you never see that when the connections are correctly aligned, coming out of the right ventricle. The transposition here, you may think that it'd be pretty straightforward to find this, but in actual fact, during the ECMO trials in Leicester, they put a baby on ECMO for persistent pulmonary hypertension of the newborn who actually had transposition. So always think, what are we dealing with? Heart failure is something that we do not tend to see commonly unless it's present at birth in terms of hydrops. But the traditional signs of poor feeding, tachycardia, breathlessness, increased work of breathing, and an oxygen requirement, of course, we can see, although sometimes after we've gone through the initial problem that the baby faced, such as respiratory distress or pneumonia. Because once the resistance falls in the lungs, then babies with heart problems that give them shunts can present in heart failure, and we need to think about that. Poor weight gain tends to be a later issue. Cardiovascular collapse can happen at any stage, and definitely if it's the first 6 weeks, even if it looks like sepsis, consider, is this a duct-dependent problem? And we can have both cyanotic and acyanotic cardiovascular collapse, so both a coarctation and a transposition of the great arteries, for instance, can cause cardiovascular collapse, and one is cyanotic and one is acyanotic. Of course, we want to resuscitate and give antibiotics, but get a diagnosis. And with later cardiovascular collapse, perhaps consider whether there's a cardiomyopathy going on or coarctation. So if we just think about a 2-day-old presenting on the postnatal ward, mother post lower segment cesarean section, probably wanting to go home, but being called because the respiratory rate is 24 per minute and the baby doesn't look right, and the severe recession, and the saturations are only 80%, and so has been put on face mask oxygen. When you feel a liver edge of 3 centimeters and the heart rate is tonking along at 180 per minute, and you know that you've got poor perfusion, then babies move to NICU for further assessment. And there you find that the blood pressure is not recordable. So you have to think, what are your priorities and what are the possible diagnoses? How would you investigate? What is the definitive treatment? Of course, you're going to take an ABC approach. You're going to make sure that you can try and oxygenate that baby properly, and you are going to undoubtedly get access, take cultures, and give antibiotics. But at this stage, do just consider whether congenital heart disease is an issue, especially with that large liver and the presentation. Because in this situation, it's coarctation and it's tight, and the duct has closed here. And so the left ventricle is effectively failing because it can't push through a very tight coarctation. And that's something which will have been potentially present towards the latter part of pregnancy. But as the duct closes, it becomes much more of an acute issue. So although we are treating and used to seeing sepsis, we need to broaden our minds and think, could it be something else? So I'm going to close it there and hope that this has been useful as a session. And I really hope that it has just highlighted why, even in your day-to-day care of both normal and a smaller number of poorly babies, you need to bear congenital heart disease in mind. And I'll stop there. Thank you.
Thank you so much again for your excellent session today. I've thoroughly enjoyed it, and I'm sure anybody who takes this on going forward will certainly enjoy it. Thank you again. I'll just stop the recording there.